pertinent subject to individuals with spinal cord injury. Just a brief bio. In 2011, Josh completed his Bachelor of Science in Nursing at McMaster University, as well as his nursing certification. He has experience in multiple areas, including surgical nursing, palliative care, and the emergency department. In 2016, Josh finished his education in wound ostomy and continence care and became an NSWOC, which is nurses specialized in wound ostomy and continence care, and went on to obtain his wound ostomy and continence care license in the same year. He's worked at Grand River Hospital as a skin, wound, and ostomy consultant since 2017, and in 2020, he took over the program when his mentor retired. Josh manages the program, caring for patients at both Grand River and Freeport sites. He also runs a company called Josh's NSWOC Service, where he provides care in the community within long-term care, CCSS, and WSIB. He is compassionate and direct, as well as an exceptional advocate for his patients. And I actually have personal experience in this area with Josh and being involved with mutual patients. So with great delight, Josh, welcome, and I'll turn it over to you.
Thank you very much for the introduction, Jamie. I greatly appreciate it. Welcome, everyone. Thank you for having me today. As they introduce, the topic we're going to cover today is wound care in patients with spinal cord injuries. Firstly, we'll just go over some quick points here. We're going to look at some costs and stats associated with pressure injuries, understanding what a pressure injury is. We're going to look at some main types of pressure injuries and those specific to spinal cord injuries. Look at some tools that we use to assess for risk of developing pressure injuries, and then get into the wound healing, barriers associated to that, and wound care production or product selection. Oh, sorry. Somehow, let me just get back here. So some quick abbreviations. SCI is going to be spinal cord injury, and we're going to go through all these here. PI is pressure injury, PU is pressure ulcer. You'll see these terms commonly throughout the paper. Some quick little history on pressure injuries. It was originally noted to be bed sores, decubitus ulcers, pressure sores, pressure ulcers. It was then changed in 2017 to be called pressure injuries, because stage 1 and deep tissue injuries, these are two injuries that don't actually have ulcers, but still are the result of pressure. So they changed the terminology. It had previously been done in Australia. Europe opted not to change it because they felt the previous ones, pressure ulcer, decubitus ulcer, were so entrenched in the medical field that they left it as is. But we did change that here. Some quick costs associated. In 2017, the cost for pressure ranged from $226,000 up to $231,000 to manage per patient. It increased nursing costs by up to 50%. A month of care in the community can be as high as $9,000. And this includes, again, your dressing selections, time for nursing, time for the patient, finding where to do the service, getting everyone out and involved. The average cost for those pressure injuries in a patient with SCIs can be as high as $4,700 for a month. In Ontario, it counts for significant costs of admission to hospitals, anywhere from $44,000 to $90,000 per admission. Excuse me. A couple of stats here. 35 out of a million, now this is a little bit older, from 2013, will experience an SCI annually. Anywhere from 25 to 30% can develop a pressure injury within the first 5 years of their injury. incidence of PIs again in 2019, for instance, was 23% in North America. Global incidence rate is 23% as well. And it's up to 95%. So almost everyone who has experienced a spinal cord injury is at risk for developing pressure injury in their lifetime. HAPCEs, so HAPCEs are hospital-acquired pressure injuries. Upwards of 50% of spinal cord injuries do develop it within their first rehabilitation. Is further 62% cervical spinal cord injuries do experience pressure injuries as well. So getting into next, what is a pressure injury? So before we do,
Can I interrupt you for a sec? I just
absolutely.
see Leamber Kensley in the chat has just asked whether these costs were Ontario costs or Canadian costs. I think that might reflect back to a couple of slides ago.
So that's a great question. Some of them are Ontario costs, but most of them are actually Canadian. So it was more specific to Canadian costs that I tried to pull versus American, because it is a little different on how it's managed. Does that answer that question?
Thanks.
Okay. So getting back to then, what is a pressure injury? In order to understand what a pressure injury is, we're first going to look at the anatomy of the skin. So we need to understand the function of the skin, which is to prevent, the primary function is prevention from invasion, from infections or anything like that. And it is also the largest organ in the body. So here in the image, you can see all the different layers of the skin. And then in the next one, it gets a little more into the minutia of it. So at the very top, we have our epidermis, and it's actually binds into two layers down to the dermis. And then where the red line is, that's the differentiation between the papillary and the reticular layers. So when we look at pressure injuries, we look at them, how deep do they penetrate into the skin and then down to the bone. So a pressure injury defined, and this is from the National Pressure Injury Institute. It's a localized damage to the skin and underlying soft tissue, usually over a bony prominence, although it can be over any area where there was a medical or other related device. So it could be anything as simple as like a blanket that was creased in that area and the patient wasn't offloaded on it in a routine manner. This is why they changed from ulcer to injury, because it can be present. It can present as intact skin or an open ulcer, and the injury can occur as a result of intense pressure, prolonged pressure, or pressure in combination with shear. So the next thing we're going to do is we're going to look at pressure versus shear. So pressure is a vertical force over a bony prominence. In this case is what we're going to talk about, the bony prominences of the patient's own weight on it against a surface, where the shear force is the horizontal force causing the bony prominence to glide across tissue that's held in place. So to get a better understanding of that, to understand where pressure versus shear is, because they do result in slightly different injuries, although ultimately the wounds themselves are treated the same in the end. But it's important to understand what's causing it, because you want to make sure that we're going to remove that injury before, or the reason for the injury, before we can move on. So here is a perfect example. So on the left side of your screen, you can see the body weight pressure pushing down against the surface. So there's your pressure. And then in the right hand is the shear force. So in this case, you have your body moving down the bed. So you're either being moved, and then the skin is moving in the opposite direction, so causing a shearing or a separation of the layers there. Next, we're going to look at common pressure injury locations for patients with SCI. So the most common areas for pressure injuries are your head, your scapula, your spines processes, your elbows, tailbones, trochanters, and then your IT bone is your largest injury area of concern, because this is where oftentimes patients will spend a lot of time sitting in a chair, and this is where we talk about correct surfaces and offloading in your tilt functions of your chair. But this is the highest risk area. Other common locations: elbows, inner knees, hips, lower backs, heels, back of head, shoulders. So these are more, as you can see in this image here, these are more from laying down. It's very interesting that the wounds actually tell you a lot about what's going on based off location and how they look. The back of the heel is a laying down injury. It's not a sitting up injury. That's due to the shape and size of the bone that's present. The inner knee often is an indicator that perhaps the patient has been laying in a certain position with its knees touching each other and not offloaded. So you can look to that as being your point of injury. A hip, maybe they were, or the trochanter, they may have been repositioning excellently to avoid a pressure injury on their coccyx, but they may have stayed over too long onto the right side, or perhaps they had a blanket that was rolled in there causing the injury. Risk factors impacting pressure injury. So here's a list of all different factors that are impacting it. So your impaired nutrition, your moist skin, body temperature, old age. But the four highlighted: limited mobility and activity, alterations of skin condition over pressure points, and then we actually separate them on the screen: diabetes mellitus and perfusion and circulation. But they really look together because your diabetes can affect your perfusion and circulation. These three areas have been found to be independent predictors of pressure injury development in patients. So again, your mobility, your altered skin conditions, and your perfusion, including diabetes mellitus. So we always take a detailed history there. Other contributing factors: gender, marital status, education, income, time from SCI. What is missing though is characteristics of the spinal lesion. So there's not a lot of research to say, where the trauma is coming, if it was if they had an existing or previous pressure injury, because we know that once we close in a pressure injury, at best, the area is only at 80% of what it used to be for tissue tolerance. And that's upwards of 2 years after the wound has been closed. And then independence and management of pressure injury. So how do they manage the injury on their own if they're able to? Next, we're going to quickly just look at some tools used to help identify patients at risk. So these are tools that anyone has access to. They can all be found online. The main ones that we look at are the Braden. So it has 6 different categories. It looks at things such as sensory perception, moisture, activity, mobility, nutrition, friction/shear. The Norton looks at physical condition, mental condition, activity, mobility, and continence. The Waterlow looks at 10 different categories. That includes gender, body mass index, skin type, mobility, continence, appetite, and then it actually has an area of special risks, which is tissue malnutrition, neurological defects, major surgeries or trauma, and medication. The other one that I also found was this SCIPCE, the Spinal Cord Injury Pressure Ulcer Scale. Now, one thing that we always look at is validity and reliability when we look at tools and instrumentations. So some of what I've found with these two, because I've actually not used this one, was that it has a low accuracy of high risk. So it actually can miss and has low internal consistency. So that means that when you give it to multiple different practitioners, they're coming up with different responses. So out of this, I would suggest that we stay away from this for the time being when we're looking at evaluating our patients for at risk for pressure injuries. There's other ones too that are used in the operating rooms, but they're more specific to that kind of environment. Next, we're going to move into wound healing. So this is kind of where we get into, well, how do we heal the wound now that we have this pressure injury that's developed? So there's 4 main phases to wound healing, or stages, I should say. The first one's hemostasis. So this one happens quite quickly. So the injury occurs, and then you start to get blood flow, constriction, the platelets start to stick together. So this normally happens within seconds to hours. Then you move into your inflammatory phase. This is where you get leak translates from the trauma. It causes your local swelling. So this is when you get the inflammation around your wound. And this is often where you find it does allow healing to occur, but if the wound's going to stall, it often stalls in this stage. So there are some dressings that help mitigate that. There are also some techniques that we can do to get it out of that state as well. Proliferation, that's when your tissue rebuilding actually starts to occur. You have collagen and extracellular matrix are used in this stage. The collagen in this stage is disorganized, as you can kind of see. They're just kind of all over the place, but they're starting to form. And so typically this can start within the first 24 hours, but last days to weeks actually, depending on how deep the wound is and how extensive it is. And then the last stage, remodeling. This is where it changes, the collagen changes state, and it becomes organized. And this can take up to 1 year. Starts kind of after a week or two, but can take up to months to even years, again, depending on how extensive the wound is. And as I noted previously, wounds are only considered healed. So that's a big difference. When I see my patients, once we've closed the wound, there's no more need for myself. I tell them, now your wound's considered closed, but it takes up to 2 years after this point to be considered healed. And at that point, again, it's only 80%. So I think that's crucial, that area of injury is always more susceptible after that point of reoccurrence, because we never gain back 100%. And that partially relates to, I can't regrow muscle, tendon, anything of that. We just grow red granular tissue to close in the area. Next portion of wound healing is nutrition. It's a very big component to it, hopefully not overlooked. In the hospital, we always have dietitians involved with any major wounds. In the community, hopefully they're linked to a dietitian, or you would take if the patient's eating well and everything else, then there's not a lot of concern there, but it's always good to link it in. These are all the things we look at. And the last one there, zinc. Zinc is a big one. Sometimes it's overmissed, but it plays a crucial role in all stages of wound healing. We'll get to that in a minute. But the other categories there, calories are needed you need extra calories, I should say, because if you need your standard 1,500 to 2,000 calories a day to heal, to just live, then you need more than that for wound healing. Your protein helps build and maintain muscle, helps with a healthy immune system. Fluid intake helps with skin health because it keeps your skin tolerance and trigger present. Vitamins and minerals helps your body repair the damaged tissue, fight infections, and helps with skin health as well. So about the zinc, zinc is something that when I'm up against a wound and we're just not moving in the direction I want, one of the things that we do is we ask about zinc levels, because in this image you can see zinc is captured or is used in all states, right at the from injury there, from the hemostasis, right through to the proliferation and remodeling. Okay, so it is a big one. It is sometimes overlooked, and so just to be kept in the back of your head, oh, you know what, this isn't going the way I want. Maybe we should look at our zinc levels. Some barriers to wound healing in patients with SCIs. So a basic dressing of normal saline and gauze would heal any wound in the right environment, but it's getting to that environment that we need to make sure we're at in order to allow that to happen. So the first one that we always look at for pressure injuries is offloading. So that can be looking at the chair they're in to see if they are tilt function, and we want specifically a tilt function like in the image seen here, where the whole thing tilts back. If you have one that just reclines the back of the wheelchair, you are not offloading the IT injuries or the IT areas, and that puts them at an increased risk for injury to occur. So you want one that has a full tilt function as much as possible. The next is the type of surface. So there's all different surfaces out there. This is a powered surface that we use for laying on if you have, your injuries laying down. So over your coccyx or the back of your head, your scapula, we look at what surface you're on. There's a powered surface like that. I teach my patients how to assess their mattress to ensure that all those air baffles are inflated all the time, because sometimes I find they'll say, I've had this mattress for years and all of a sudden I have this injury. And what can happen is one of the air baffles within will get disconnected, or it can rip, and then it's not effective, and that's where your injury comes from. Another one is the ROHO here. So these are cushions that you find both on chairs as well as on your beds. You do have full ROHO mattresses, partial ROHO mattresses, and the same thing, checking those routinely to ensure they're properly inflated, that none of the nipples are ripped or leaking or anything of that sort. And the other one is just your more specialty surfaces. So these are ones that you find similar in hospital often. There are similar ones that you can get in long-term care and in community. And so these have a gel matrix that helps offload pressure. The key thing is that all these have a lifespan. So you may have had it for years, but it still needs to be assessed. Oh, I've never had a problem. They do have lifespans, especially if we're not having them checked out routinely. So the first thing that I always do is we look at the surface to ensure it's correct and functioning as we expect it. Next is nutrition. So as we noted with the previous slide, nutrition is very important. So you want to maintain a good blood glucose, because proper sugar tolerances are vital to wound healing. Proteins such as cheese, cottage cheese, eggs, fortified soy, fluids, your water, your milk or fortified soy beverages, veggie juice or fruit juice, soups, coffees, teas, keeping in mind that some of those things such as coffee can dehydrate you with the caffeine present. Your vitamin A you can get from apricots, cantaloupes, carrots, cheese, vitamin C from broccoli, Brussels sprouts, cantaloupes. Zinc, as mentioned, we can add it into our diet. So you find zinc in things like eggs, fish, legumes, liver, milk, meat, nuts, and so on. So always checking in to the nutritional status, and if we need a dietitian involved, then we ask for a consult on that. The other barrier that we sometimes run into is continence for our patients. So They may have this injury over their IT, but one of the issues is they're incontinent of urine. So how can we manage that? For males, it might be something using a condom catheter. This is a device that slips over top of the shaft of the penis and then attaches to a drainage bag. They could also get a Foley catheter, which is inserted into the bladder. The thing with those, you need to be careful about introducing infections, so weighing the pros and the cons. Some newer devices that are coming to the market, I'm going to just pull both these up, are called the Prima Fit on the right and the Primo Fit on the left. So these are newer devices that have come, so they're external female and male urinary management systems. So these do require suction. So it might be a little difficult in the home sometimes, but there are pumps available that you could get to marry up with them. But this removes the concern for infections related to indwelling catheters. And interestingly, the Prima Fit is the original design. They've recently made the Primo Fit, but the Prima Fit was made by a gentleman, I believe in the States, whose wife was in bed and always had issues with incontinence. And he kept saying, there's got to be something you can do. And what he did is he rigged up a system using just a piece of like PVC pipe and two air hoses, that he would put between his wife's labia, and it would actually pull away the urine from her skin and resolve her issue. From that, we now have the Prima Fit, which is based off that design and has good results. And then the last is continence care, or sorry, bowel care. Some patients I have found with SCIs, they have some issues with constipation due to the innervation from the spinal cord injury, or lack thereof. The Prima Fit, the Pristine, is an irrigation system that has been shown to have good benefit because they can use it to irrigate their bowels, and instead of having to get on a commode daily to help evacuate the bowels, they can use this system 2 or 3 times a week. This system is a little costly, though, I'll be honest with you. But if it can help get you off a commode for 2-3 hours a day, there is a trade-up there sometimes. Now we'll move into wound care product selection. So this is where we get involved in the direct care and closure of the wounds. So when I'm looking at a wound, a couple of things that will affect how I choose, because again, there are many options out there. Most, if not all of them, work. It's just deciding which one to use and in which different situation. So some of the factors that I look at, or that need to be looked at, are what is in the wound bed tissue itself. So is it vitalized? So is it slough or eschar, or is it a robust, healthy red granular base? The exudate, the amount and type. The peri wound, is it macerated or excoriated? And why? We just need a better dressing selection. Infection, pain, undermining, frequency of change. Do we want to be changing this every day? Or can we get away with every other day if we modify other things like their bowel routine? The location of the wound, the cost of the dressing. There are definitely dressings out there that are very costly. They work great, but are they actually needed in that case? And then the last is accessibility. Accessibility to them. So when we talk, first we look at wound cleansers. So if we need to decide, is the wound infected? Do we need something to help clean it out or not? So we have all these different varieties here. WOCC is hypochlorous acid pH balance, similar to Dakin's, but it's pH balanced, so it's better on the skin. Iodine, Frontisan is a surfactant cleaner. Acetic acid, so that's your run-of-the-mill table vinegar. Do we need that? And then there's also hydrogen peroxide. So the two of them that we keep in mind with are Dakin's well was, when it came about, was a game changer in wound care. But as we have advanced our understanding of wounds and cellular matrix and everything of that, we find that Dakin's is actually can be cytotoxic to intact skin. So we try and avoid that and instead look at something like WOCC, which is pH balanced, so it's not cytotoxic. The other one that we also want to try and stay away from is hydrogen peroxide, because the same as the other ones, it too is cytotoxic. So long term, it will actually cause some cell death and not give us the end result we're looking for. Dressing selection. So here's where then we come in and we decide, okay, what are we going to put on this? So at the very bottom, there is basic dressing. So this is your gauze. It's cheap and cheerful, easy to use, needs to be changed every day. But it's something that if you're concerned about infection and you want to be changing frequently, you would switch to gauze, because it's going to force you to change the dressing every day or more often than that. And it is one of the most readily available products out there. There's multiple manufacturers of it. Very rarely will you find it going on back order. And if you do, it's only one manufacturer. You can flip to the other 13 that are available in your area. So you would pick something like that. Another one would be our cover dressing. So this is your border foam silicone. So this has a nice intact border, or silicone border, sorry, that will help prevent any peri-wound trauma when it's being removed. The nuances with this one, though, are understanding the different sort of specialties each dressing carries. So for instance, the top right one, Meplex Border Flex, it's designed to really hug into all the different curves that might be present. So if you're doing an CAPCE, it will really hug into that wound nicely and hold tight to the area. Where the biotin silicone, what it's known for is as exudate hits it, it will actually suction down, assuming the wound's not too deep, into the wound base itself, so you get complete contact. More advanced dressings are your collagen. So for instance, the chromogram, it's bioabsorbable, it aids in stalled wounds. So if the wound's not moving along well, we can switch to something like that. One of the things is it's costly. So the reason it requires monitoring is because you don't want to use it longer than necessary because of the cost. But it is a good dressing when needed. There is also hydrofibers. So these are man-made products. Multiple companies wear it. It allows you longer wear time, anywhere from, well, 3, 5, 7 days, depends if there's silver or anything of that's antimicrobial in it. One of the drawbacks of it are if the wound is not moist enough, it can be painful to remove. But if the right moisture balance is present, then it actually gels and helps with wound healing and is easier to remove then. If there's concern for an infection to the wound, then we look at antimicrobials. And this, I think, by far is the most complex option of dressings, in my opinion, because each antimicrobial offers slightly different fight against organisms, and we'll look at that the next page. But on here, there's things that have silver in it. There's different types of silver. There's PPMH. So understanding what it is, there's inidine impregnated dressings. But a recent example I had of this in understanding how to do it is I had a patient who had a coccyx pressure injury, And when I went to assess him, I noticed that the wound appears stalled to me. So this simply means that the wound didn't look robust. It looked more pale red in comparison. Wasn't a lot of change. And so when I find a wound like that, whatever I'm doing on the dressing, being in any of the previous ones or other ones we're going to look at after this, I always stop it and I flip it over to iodine. And so that's what I did in this case. I flipped it over to iodine. I changed it to a daily dressing, and I was going to go back in a week and assess it. So that same day, the physician that I work with read my note, went and had the staff swab the wound, and lo and behold, it came back with Klebsiella. So this is not an organism that I am familiar with up until this point. I'm very familiar with it now. So I pulled up this table here that I use as a resource all the time. It was developed by British Columbia Nursing and Wound Committee. It's a fabulous resource. And lo and behold, my iodine was not going to be effective against that organism. So using this table, I was able to select another solution to help with that. And we moved it over to hypochlorous acid, or the WOCC, which I had on hand. And we were able to switch it over. So this is why I think that highlights the importance of understanding the dressings that they're using and how each one affects different organisms. Interestingly, I was going to switch this patient over to BMHB, which is Curlex, and I don't know if you can see this, but it was actually effective against it. So we would have had some good results after the iodine, but we weren't going to do anything for that week leading up to it, unfortunately.
Josh?
Yes.
Can I just ask a question from the chat there? James Heckner just asked, do they still recommend or use Duoderm?
So hydrocolloids, yes, they do. I guess it's kind of in the context that Duoderms or hydrocolloids are meant for low exudating wounds. So you can use it as a cover dressing, absolutely. I tend to avoid them a bit because out of sight, out of mind. So I like someone to be able to check on that. That's not a dressing that you can see through or easily peel back to assess the wound. It's the same thing if you noted on the offloading. I didn't mention anything about heel boots, because I find with those, we put them on and they have great intent and they work well when used correctly. But what happens, I find from time to time, is we put the boots on and we don't necessarily look at the heels. We just glance in, oh, yep, Mr. Smith has his heel boots on, he's good to go. When in actual fact, we've missed that the heel's misaligned or it's shifted, and so it's actually causing pressure injuries. But yeah, so no, hydrocolloids, great to use. Just be mindful that you need to be reassessing what's underneath them.
Hi, Josh. Can I throw just one quick comment in there, just as a spinal cord injury?
Yes, sir.
Yeah, sorry about that. Just I wanted to question that because I mean, 25 years in spinal cord injury, and I haven't heard a lot of that recently, but 25 years ago, it seemed to be quite prevalent. When I used a Roho cushion for, almost 20 years, I would have basically a stage 1, stage 2 all the time. Okay. Just because of the, hip obliquity and such, and that pressure just on that one IT. And when I would use that thick Duoderm and have it on there for 3, 4, maybe 5 days, if it stays on there along with the skin tape on top of it, boy, it just seemed to clean it right up. But I wasn't sure if that's still something that, clinicians recommend, but obviously you can't see the progress. So understandably.
Yeah. So one thing I should, that's a great point. I actually mismentioned. If we go back here real quick, so can you see the Metflex border up on the right that we had talked about there? So when I talk about it contours in, I should mention that there has been research done with that dressing and it's specific to this one. It's not the biotin silicone. It's not It's not Convitex, Aquacel silicone dressing. It's just the Meplex Border Flex. It's actually been shown to redistribute some pressure over the dressing. So in your case, sir, it might be great to trial one of those dressings in. It's the nice thing about it is it's silicone. So that means that someone can actually peel the dressing back every day, take a peek at the area and reaffix it. And you want to pick a nice big one, much larger than the area of concern. So one thing I find is that when on this page here, I put often wrong size selected. They may have like a 2x2 injury, so they're picking the smaller size because it fits the dressing. But what we're really looking to do is we want to get as big as we can to redistribute that pressure as much as we can, right? This isn't the savior of it because it's not going to remove pressure. It just is one more thing that we can help redistribute the pressure. Oh, I think you're on mute there.
Sorry. Yeah, thanks. The one thing I experienced with the Medplex though is the, you know, typically, like you said, we're getting the pressure injuries on, you know, our ITs, you know, because we're sitting all day. And when you have a little bit of that shearing, of course, not maybe necessarily detrimental, but when you're doing your transfers and such, it does start to fold. So can you use like skin tape on the side of that to hold it down so that it just stays in place, meaning that it still has room to breathe?
You absolutely could use it on the leading edge where you're finding that rolling occurring. I wouldn't do it on the whole thing because again, you want that ability to look at it. But absolutely, if you're finding it's your right IT, and so it's always the lateral or outside edge that's rolling, 100%. Put a piece of tape there. If you want to use, you know, even a tegaderm, which I don't often recommend, but you could just put one there because that tegaderm, it's got that slippery surface, so it might just allow that slide over for your transfer.
Perfect. Thank you.
No problem. So we'll just bump back up here. We'll go through my animations again. So the next one we're going to look at was negative pressure. This is the one everyone asks about. Oh, I want negative pressure. I want negative pressure. So the research is there. It has been shown to decrease time to closure. Absolutely. It's got limited dressing changes, so you can extend it out. The guideline, sorry, is change it every 72 hours or 3 days, depending on location. Sometimes it's a little higher. Sometimes you can stretch that out somewhat. There has been some research that it decreases rate of infection, and that's simply by the fact that the wound itself is now sealed in, creating that subatmospheric pressure. And so that's what negative pressure does. Is you fill the wound with a foam of some sort, or a filler. It doesn't have to be a foam. Curlex was used for a long time. And then you seal it with tegaderm in this case. And then you put a subatmospheric pressure. The pressure used is -125 in most of the bigger pumps. But there are some newer dressings out there. The bottom left of the pictures there, that's a disposable one from Smith & Nephew called a Pico. That one utilizes 80 millimeters, minus 80 millimeters of mercury of pressure, with good results for closure as well. The two main limitations are cost and training. So they can be cost prohibitive, and you also have to spend time with who's ever going to be applying the dressing on how to do it correctly. It's not, people find it to be intimidating. And I think just because you have this big machine that's going on, but it truly is not. What I find now is I start to use the bigger machines to start the closure, and then we can flip it over to the Pico. And the Pico dressing, if you can put a Meplex border on, you can put one of these on, change twice a week. It's a 7-day pump, and you get another one and keep going. Moving into more advanced, more advanced, I guess, is eStim. So eStim is this machine over here. It does provide some electrostimulation through there, monophasic or biphasic, depending on the dressing you're using. There is some mixed results on this. So when you look at some of the research, specifically through Health Quality Ontario, when they looked at it, they found some mixed results that they weren't sure it actually improved time to closure, but it seems to be an okay adjunct therapy. You need to be careful about dressing interaction, again, cost and training as well, but that is definitely one that's absolutely out there. Another one that we look at is continuous O2 treatment. So this is Oxygenie. There's other ones out there. So it's been shown to decrease time to closure, because one of the things we know with wound healing is we need that, we talked about it earlier, one of the barriers is perfusion to that tissue. So what this does with that dressing is it actually helps deliver extra oxygenation through this little machine here to the wound bed itself. You can expect some increased exudate or drainage with it at the onset, but it definitely is another option out there. Cons, it needs to have contact with the wound base. So if your wound has significant depth to it, you may not be able to apply it on right away. And then the other two are cost and training associated with it. Next will be hyperbaric treatment. So again, this is very similar to the oxygen treatment, but in a full body application. So it has also been shown to be decreased time to closure. And there are some certain circumstances where it is actually covered by OHIP, which is nice. But if it's not covered by OHIP, then it can be quite costly out of pocket. You may need up to 50 or 60 treatments, I believe. The assessment each session runs about an hour long. You'll be in one of those chambers there, and location. If you live in the north and there's not one around, you have to come all the way down to St. Catharines to utilize it. It may not be an option. You can get a referral. To have OHIP coverage, you need a referral from a physician. But if you're going to pay out of pocket, you can self-refer. And then my understanding is there's for each case, actually, either physician referral or self-referral, there is a team of physicians that reviews your wounds and determines if they feel it would help in that situation. And then the last one, which isn't really a wound dressing per se and not something involved in, but I did want to mention it here, is plastic reconstruction. So this is where you has consult to a plastic surgeon and they would do some sort of graft to the area. It is OHIP covered. If it's on your IT or your coccyx, though, it often requires you to have an ostomy, which is a fecal diversion, to have stool come out through an opening created in your abdomen. And it also requires, my understanding, most of the surgeons actually have you contract to staying in the prone positions for 6 weeks of rehab. And again, you have to find a surgeon who would do it. So where I am in Grand River Hospital, we don't have surgeons. We have plastic surgeons, but not ones who do these flaps for us. So we have to send our patients out. That about covers it for the different dressings. I think it's important to note that any of these dressings are great. It's all just in the context of what the wound's presenting and what we need to do with the wound. I use most of these in my daily practice. Sometimes I'll use multiple ones with a patient to get the desired result, but they all have their benefits. Here's my reference list. And then any questions? This page was for my kids. They wanted me to put the fireworks in. Go for it.
Yeah, absolutely. Now this is great. Obviously, it's always good to talk about healing pressure injuries and just being aware of them. I know one of the mentions there on the topics about prevention, obviously, about pressure injuries. And I work for Praxis Spinal Cord Institute. One of my colleagues, Shannon Rockwell, is an occupational therapist. We do a lot of education sessions out here in the interior of British Columbia. And a lot of this is on prevention. And I really feel it might be beneficial in a consecutive session here to talk about different types of equipment and such, because, you know, we are only as good as our equipment. And with some of the new technologies that are available, more recently in the last decade, you know, offloading cushions. Most of our community out here uses offloaded cushions, which is a huge prevention, as long as that orthotic is actually set up properly. Obviously, when you're going into the hospital, that's, you know, you mentioned it in here about the statistics about acquiring a pressure injury as a secondary complication if you're going in for some other, you know, situation. And so that's what we're really pushing out here, is to make sure that when somebody is going in to the hospital for something, that we have a higher end mattress, as high end as you can possibly get, but, you know, definitely more adequate than what you would normally use for an able-bodied, fully functional client or patient. So yeah, I think that might be beneficial for another session, is just to go through and let's talk about equipment, because it's yeah, the prevention is absolutely essential for eliminating these pressure injuries.
Yeah, I think I can't speak to doing the presentation. I'll leave that to Allison and James. But as far as the services, you're absolutely right. So like I said, I work at Grand River Hospital, and I know there is a big trend to standardize services in each hospital. Like I'm focusing on trying to get ISO tours into every bed, so that it doesn't matter where you're coming into my building. I know that if you're being admitted, you're going on the best surface for you in our organization. There's other hospitals that are seeing the same thing. I know there's some places in Toronto and London where they have moved that way. So it is no longer a concern that you come in and you're, no matter what bed you're going to be put on, you get on that surface, because that's absolutely correct. That is key. My team at Grand River, we have a small client base, I'm going to say, who tends to come and go, and we know. So if you're coming into a hospital, we'd see your name pop up on our list, and you instantly get ordered a surface right now, because we're building that to have everyone. But we have that to help with that as well, because yeah, it is vital. Any other questions?
Maybe I'll pipe in one more time here, Josh, and it's basically one thing that we really put here in the rehab centers and the hospitals is any surface that we're using, right? So whether that be you know, bath benches, commodes, some people acquire them by just sitting on their couch and watching Netflix. You know, you know, obviously the patient has to be extremely aware, or not necessarily a patient at that point, but you know what I mean. And so it's basically any surface. And I basically say, you know, protecting our assets. That's what it is. And what can we do? You know, what equipment is necessary for that, that type of prevention. And I think that it's probably also really important to note that a lot of incomplete spinal cord injuries that may have just reduced sensation are even higher at risk, because they don't tend to check their skin as often. So because they're just relying on the sensation that they have, and that can be very, very difficult, or you know, to manage. So anyways, just a couple other points, but excellent presentation. Thank you.
Oh, absolutely. I appreciate that. Thank you. Yeah, no, it's very true, right? Checking that all out. And that's why I mentioned, if you remember on the continents, the peristine anal irrigation. because that is, I have a client right now that was absolutely the issue is things were in place, but his bowel routine was 2.5 hours on a commode, slightly tilted to onto his left IT so he could manually stimulate, and he ended up with the stage 4. And so I think, was that really the best option? If we got this anal irrigation in where it's done twice a week in the bed, he wouldn't need to be on that commode at all, essentially, right? And we could avoid that whole thing. So it is a more costly option for sure. But those who have insurance, or unfortunately if it was WSIB, the research around it has been really good. And actually in that study, when they were taken away because the study ended, the people really complained about it because it really impacted their quality of life. And ultimately that's what we're here for, right? Is to keep your quality of life.
All right. Thanks, Josh. We're at the end of time, so I'll just kind of wrap up. Again, want to thank you for the great presentation. Thank everybody for attending and interacting. If people do have topics for suggestion, you can always reach out to Allison, who sends out the invites. And James, maybe we'll reach out to you about, that kind of a topic, which I think would be an excellent idea, and whether there may be somebody who can do that. So thanks